I am going to record the presentation as well, so I can email it to everybody afterwards. And for those that weren't able to make it tonight, you can email it and you can pass along to anybody that you feel might benefit from it as well. So thank you, everybody, for joining us tonight. My name is Jennifer Lombardo. I'm from Rothman. I oversee our community relations department. We just want to thank everybody for joining us. I know it's a tough time, and we normally do these lectures in person, but under circumstances, we've decided to do some virtual lectures so we can continue to educate and be able to answer any questions that anybody may have for certain topics. So the lecture this evening will be given by Dr. Brandon Erickson. Dr. Erickson is one of our sports medicine surgeons at Rothman. Dr. Erickson currently sees patients in our office in Manhattan at our Gramercy location and also in Harrison, New York. His topic he's going to be speaking on today is a knee shoulder replacement. What should I expect? So again, if anybody has any questions, there's a chat section at the bottom of the screen. So you can type your questions in there, or you can unmute yourself at the end of the lecture and you can, just ask it out loud. I am going to put everybody on mute, obviously, besides Dr. Erickson during the presentation, so we don't hear any background noise in the meantime.
A major duty.
Okay.
All right, so Jen, you tell me when you're ready and I'll transfer to the screen.
I'm ready.
All right, so let me just share that screen that I have going on here real quick. All right. Okay, get this thing out of the way here. All right, so thanks for tuning in. My name is Brandon Erickson. I'm one of the sports and shoulder and elbow surgeons up here at Rothman. And today I thought we'd talk a little bit about shoulder replacements. We'll talk a little bit about the anatomy and the function and who needs a shoulder replacement and what you can kind of expect once you have it. I have nothing relevant to disclose for this. So I get this question a lot, and people think about hip and knee arthritis a lot, but they don't usually think about shoulder replacements as much. And if you think about why shoulder arthritis makes a difference, well, there's really hundreds of thousands of patients, certainly throughout the United States and of course throughout the world, that suffer from shoulder arthritis annually. And there's about a 10% annual growth rate in the number of shoulder replacements that are performed each year. And if you look at some of the studies, it actually shows almost a little higher than a 750% increase in the number of shoulder replacements that are going to be performed by 2030. So there is some growth in hip and knee replacements, but shoulder arthritis seems to be more and more popular, and shoulder replacements seem to be becoming more and more popular with time. And so one of the things about shoulder arthritis is that there's a lot of different causes of shoulder arthritis, okay? This is called osteoarthritis, and you can see this little beard osteophyte that's formed down there where that arrow's pointing to. This is something called rotator cuff tear arthropathy, and I'll talk to you about that a little bit later, but this is when your rotator cuff is not functioning properly, and you wind up getting the ball part of the ball and socket, as you can see here, to slide up. So this is where it should sit. It should be lined up relatively well with the socket here, but when it slides up like that, it can cause a problem. This is arthritis that you can get from trauma. So this is the shoulder that's been dislocated. And if you dislocate the shoulder a bunch of times, you can cause some damage to the shoulder. And certainly if you have a fracture, as you can see here, that the shoulder's in a bunch of different pieces, that can also lead to some arthritis in the shoulder. So let's talk about that first one, that glenohumeral osteoarthritis. Well, a lot of times you can talk to your parents about why you have this, because a lot of this is hereditary. We know that there's certainly an increased risk of patients to develop arthritis if family members have had this before. Certainly, if you look at your hip, you look at your knee, there's really no dominant hip and dominant knee. When you look at the shoulder, of course, most people are very either right-handed or left-handed, so they wind up putting a lot more stress through one of their shoulders. And usually that shoulder tends to get arthritic more than the other side. Now, that's not to say you can't have the same thing going on in both shoulders, but oftentimes the dominant arm, because that arm sees a lot more stress and load, will be the one that gets affected first. And then, of course, occupation. So if you're somebody who's had to lift heavy things over your head for your entire life, if you've seen some trauma because of your occupation that you do, if you live a heavy manual labor job, that can, of course, increase your risk of shoulder arthritis. And the reason is because as you're lifting things over your head, you're loading your shoulder joint. Every time you take a step, you load your hip and your knee. But when you lift things out away from your body and over your head, you're loading your shoulder joint, and that can increase the risk of getting arthritis. And I guess I should say, what arthritis is basically loss of cartilage over here. So if you look at this image here, this is the socket, and this is the ball. And there should be at least 3 to 4 millimeters of space in between this ball and socket here, and that's where the cartilage lies. But as you start to develop arthritis, you'll notice that the space between the bones starts to narrow, and this is what we kind of call that bone-on-bone arthritis that people get, where you can feel that crunching and grinding sensation in the shoulder. When you're born, if you think about a newly paved road and fresh tires kind of gliding over a newly paved road, that's what a normal shoulder articulation should be like. It should be nice and smooth, no divots, no potholes. But as you start to get older, you start to use your shoulder more, you start to wear away some of that cartilage. It's almost like a car that needs new tires, trying to drive over a road that really could use some new gravel and some new pavement from all the potholes that it has, and things can catch and they can click and they can hurt. And that's why shoulder arthritis tends to cause a problem. The main function of the shoulder is actually to position the arm in space. That's really what the shoulder has to do. And so when it can't do that because it can't lift the shoulder up properly because it's very painful, that's when people usually come to see me. I mentioned before that rotator cuff tear arthropathy, and the reason you get that is because the rotator cuff is not functioning properly. And I'll go over a little bit later what the rotator cuff is, but that's one of the types of arthritis that you can get. As I told you, you can get some post-traumatic or after a trauma to the shoulder arthritis, because when you have a trauma to the shoulder, you start to damage that cartilage. You start to create those potholes that I talked about in the cartilage surface. So that can happen from recurrent dislocations over time, or it can happen because you had a fracture if you fell and broke your shoulder into a few pieces, as you can see in that picture on the bottom there. Now, as far as why shoulder arthritis is relevant and how it affects people, well, when it starts to affect activities of daily living is usually when people come see me. When they can't put their dishes away in the cupboard above their head, when they have pain at night that wakes them up, when it really impedes them from doing the things they want to do is oftentimes when they come in and see me in the office. Certainly athletics can play a role in this, and oftentimes it's golf and tennis in patients that start to have shoulder arthritis, that it starts to bother them either as they swing through, they're starting to get pain, when they try to hit a backhand or a forehand or certainly serve overhead, that can cause pain in somebody who has shoulder arthritis. And of course, pain is one of the biggest issues with this. When it wakes people up at night or when they can't do what they want to do, oftentimes they'll come see me in the office. The other thing is dysfunction. So when you start to lose your range of motion because the shoulder gets stiff or the rotator cuff is not functioning properly, that can be a real big problem. So if you can't lift your shoulder above, mid-waist height or certainly get it over your head, it can really hurt people when they have to do things like do their hair, get dressed, and oftentimes I'll see them in the office when they have issues like that. And of course, pain at night that keeps people awake and doesn't allow them to sleep, that can also be a significant problem with the shoulder. And I kind of mentioned the difference between shoulder and hip and knee arthritis. Well, the shoulder is not a weight-bearing joint. So you can tolerate a lot more in the shoulder than you can in the hip and the knee, because every time you step, you're not irritating your shoulder. But like I talked about, handedness really does play a role in the shoulder, whereas in the hip and knee, that really isn't super relevant. In the hip and the knee, we know that if you have some arthritis and you lose some weight, it actually takes a lot of load off of the hip and knee and actually can help out to a great deal. We're still not sure if weight loss helps in the shoulder. It certainly helps from an overall health perspective, but as far as the shoulder arthritis is concerned, we're not sure if that actually helps as far as pain goes. And then oftentimes we're going to start with non-operative management of both of these things. And when we talk about non-operative treatment, these are things like physical therapy, anti-inflammatory medications. Of course, right now with the virus, we have to be careful with the anti-inflammatory medications, steroid injections, and sometimes these gel shots, which are kind of like WD-40 for the shoulder. We use them in the hip. We use them in the knee because they're approved for the knee. They're not FDA approved for things like the shoulder and the hip yet, and so they're kind of experimental still for those types of arthritis. There's other things to hear about like platelet-rich plasma or PRP, stem cell treatments, things like that. And we're not really sure exactly how much these injections benefit people with shoulder arthritis. They're not usually going to cause a problem, but I can't tell you with absolute certainty how much benefit you're going to get from these injections. So these aren't things that I usually go to unless somebody really wants to try it. Now, I mentioned steroid injections. There's just one thing that I want to mention about steroid injections. They can be very effective, and we certainly use them in the knee and the hip a lot. But as far as the shoulder goes, the shoulder is a different type of joint where the rotator cuff has to function. And so we know that if we give patients injections into the shoulder, or steroid injections specifically, we know that there's a slight increased risk of an infection if you were to operate on that shoulder. So if you were to do a shoulder replacement within 3 months of getting the injection. So anybody who sees me for a steroid injection to the shoulder, I always tell them we have to wait at least 3 months from this injection before we do any type of replacement to your shoulder, because your risk of getting an infection is slightly higher based on one of these studies that was done. And this is some pretty good information. And so we're really talking about shoulder replacements today. Of course, there are some arthroscopic treatments, using some small poke holes that we can do for kind of mild cases of arthritis. But when you get to the point where you have significant shoulder arthritis, we're usually talking about a shoulder replacement. And there's a couple of kinds of shoulder replacements. There's that picture in the middle here, which is called an anatomic shoulder replacement, meaning we keep the ball where it is and the socket where it is. We cut out the arthritis and we replace it with metal and plastic, but we keep the shoulder functioning the way it was before, and this requires a functioning rotator cuff. This picture over here, this is of a reverse shoulder replacement. And the reason it's called a reverse is because we're switching where the ball and the socket are, okay? So the ball is now here and the socket is now here. And the reason this works well is because this actually takes away the need to have a functioning rotator cuff for you to be able to power that shoulder replacement. We've kind of modified our designs a little bit, so we actually moved to these stemless designs, so we start to take less bone away. So it's a slightly easier recovery, the pain's slightly better, and if we had to go back in for whatever reason, we still have preserved all of this bone here. So this is what I do now when I do the regular anatomics. I use this stemless device now. The other thing I mentioned before is you can have shoulder arthritis from a fracture. And what happens when you have a bad fracture like this, where there's a bunch of pieces to where that ball was before, we can change that into this over here, which is our reverse replacement, where you have, again, the ball here and the socket here. We kind of tag all of those pieces of bone back down around the replacement. And again, this takes away the need to have a functioning rotator cuff, because when you have a fracture like this, the rotator cuff is attached to all of those pieces of bone. And so if you were to do a regular shoulder replacement, you would have to rely on all of those pieces of bone healing exactly properly for you to have a functioning shoulder. When we do this, where we switch where the ball and the socket are, it actually takes that need away. And so patients generally do much better from this in the setting of a fracture like this. Now, we've done a lot of work on shoulder replacements in regards to range of motion and the right way to do this. These are some of our papers we've done over the years, and I'm happy to share these with any of you. But this is just how we're trying to kind of advance the field of shoulder replacements and try to make the recovery better, and try to give everybody the best outcome possible. Now, the reason to have a shoulder replacement, when we talk about hip and knee replacements, it's kind of similar principles. For a shoulder replacement in particular, the main goal of a shoulder replacement is to help with pain, okay? If you're not having any pain, it's very difficult to say if I do something to your shoulder, you're going to get significantly better. If you can't lift your arm up at all, but you don't have pain, that's a different story. But the main goal of doing a shoulder replacement is to help with your pain. A secondary goal is to kind of help maintain or even restore some motion. So if you're really not able to get your shoulder up past 20 or 30 degrees, the hope is that after we do a shoulder replacement, because I go and I release a lot of scar tissue and tight tissue that's there, that your motion will get better as well. Now, oftentimes that does happen, but again, the main goal is to get rid of your pain. We try to improve your quality of life after a replacement, and we also want you to get back to playing sports, whether that's tennis, golf, etc., after a shoulder replacement. But again, the main goal is to help your pain get better. Now, what's the process like when you need a shoulder replacement? Let's say you've tried the non-operative management, it hasn't worked, and so now you've decided, okay, I'm going to have a shoulder replacement. Well, what does that mean? Well, I always see you in the office beforehand, and I always have to do a physical exam because I want to know what your shoulder motion's like. I want to know if it feels like your rotator cuff is functioning properly. And I want to get a set of x-rays because I want to know what your general bony anatomy is like. And then you and I have a discussion about what it's like to have a shoulder replacement, and I'll go through some of that with you now. After we're done in the office and we say, okay, we're going to go ahead with the shoulder replacement, I have you get a CAT scan, and sometimes I have you get an MRI. The MRI's purpose is to look at the rotator cuff, because if we're deciding between a regular anatomic replacement and a reverse replacement, it's really important to get an MRI to make sure that the rotator cuff is functioning properly. Because remember what I told you, if the rotator cuff is not functioning and you try to put in a regular anatomic replacement, it's not going to be so great. So that's when we go to the reverse. And then, of course, we have to plan for surgery. So the reason you get the CAT scan is because I make all of these measurements on the CAT scans that you get. These are a couple of the views that I like to use. And I make these measurements of what the inclination of the shoulder is and how much the shoulder is tipped back, so that when I go into surgery, I already know what your shoulder is going to look like, so there's no surprises. Of course, we're always prepared for everything, but it's always good to have a plan when you go in and try to execute that plan to the best of your ability. Now, the other thing I do when I get your CAT scan is I put it into this preoperative planning software, which is really neat. This is new in the past few years, and some of us that do a lot of shoulder replacements oftentimes use this. And what this is a 3D system, and I can change the position of where I'm putting the socket part of this here, and it actually allows me to put that in the perfect position. So I can change things like moving it to the front or the back, or a little deeper, a little less deep, and changing the tilt on it a little bit to get your shoulder in the perfect position, so that every time we go in, we have a plan and we can execute the plan so that you get the best outcome possible. This is the plan that I get and what it looks like. And that little device here that you're looking at, I actually have that device in surgery, and that's actually what I use as my guide to place the pin in that I kind of base a lot of other things off of. So that's why it's very important to do this. It's a little extra work to do it beforehand, but it helps us to make sure that we're doing this absolutely perfect every time. Now, I mentioned the rotator cuff report. I just want to give you a brief kind of talk about that. Now, the rotator cuff is made up of 4 muscles and tendons, and what it does is it helps center the humerus, or the ball, within the socket, okay? There's the subscap, which is in the front, the supraspinatus on the top, and then the infraspinatus and the teres minor around the back. And they help you move the shoulder in different directions. The subscap is out to the side, the infraspinatus is towards your stomach, the supraspinatus is away from you, the teres minor is almost the position of you're throwing a baseball. And all of these tendons have to be functioning properly to move along with an anatomic replacement. Again, if they're not functioning properly, then we move on to the reverse. And the reason is because if you look here, this paper that was done years ago, but is a really nice drawing, if you look at this view here, this is the ball and this is the socket, and these are all the different forces acting on the shoulder. If these tendons here, muscles, are not functioning properly, it allows this to slide in funny directions, and it allows it to escape up or to the front. And so that can cause a problem if we don't wind up doing a reverse shoulder replacement in this setting. This is why it looks like this. So if the humeral head right here, the ball is riding up, this is when we talk about doing something like this, which is the reverse shoulder replacement. Now, as far as now we've decided that you're having surgery, you've gotten your CAT scan, we've had a talk beforehand, we decided on what type of shoulder surgery we're doing, then we have to pick the place we're going to do it. And there's a couple of options, and we've kind of pioneered doing shoulder surgery as an outpatient. It was done in Chicago for a while, and we started doing it here in New York. And basically, you can have the surgery done in a hospital or in an ambulatory setting, and there's a lot of subtle differences that go into that. Most patients are going to have this done in a hospital because you can stay overnight, and if you need to, if you're sick, if you have a lot of medical issues, you have the ability to stay in the hospital. If you're relatively healthy and you want to go home the same day, that's when we talk about doing it in an outpatient center. And this is really done on a person-by-person basis, and this is a discussion between you, me, the anesthesia team, your primary care doctor, to find out where the best place for you to do it is. This is just a paper showing that as we start to move towards the outpatient surgery, that actually people do quite well with this. We use some things to try to help minimize blood loss in shoulder surgery now. We sometimes used to put drains in patients before, so we would take that out the day after. But actually, we've stopped doing that, and we use this new medicine. It's called tranexamic acid, or TXA. And what that does is it actually helps stop a lot of the bleeding that you get in the shoulder with the shoulder replacement. The doctors who do hip replacements and knee replacements use this as well. It's been a very effective tool for us. It's actually helped us improve our outcomes over the last few years. Now, before surgery, so let's talk about the couple of days leading up to surgery. Well, you have a checkup with your medical doctor. You want to make sure there's no issues with going ahead with surgery. If there's anything that has to be done to make sure surgery is safe, we have to do that beforehand, so we make sure that you do that. I have you start washing the shoulder area of where the incision is going to be with something that contains benzoyl peroxide, starting about 3 days before surgery. And the picture down here on the right is actually where that incision is. It's a little bit smaller than that, but that's where the incision is in your shoulder. This is the outside of your shoulder. Your head's over here, and you're kind of sitting up a little bit. And this is where the incision goes. And I have you wipe this area in your armpit with something that has benzoyl peroxide in it because it kills some of the bugs that live on the skin, specifically one called P. acnes, because that can be a problem with shoulder replacements if that bug gets inside and can infect the shoulder replacement. So we do our best to mitigate that risk by having you use these pads ahead of time. And then, of course, we don't let you eat or drink anything after midnight the night before surgery. Now, the day of surgery, you're going to arrive at the hospital or the outpatient center. You're going to come in a few hours before surgery. You're going to get an IV started. You're going to talk to the anesthesia team. And usually I have you get a block, so a local anesthetic that the anesthesiologist team does under ultrasound guidance to basically numb up your arm. And that helps control your pain. It helps them to use less anesthesia during surgery, and it keeps your pain controlled for the first usually 10 to 14 hours after surgery. Everybody's a little different, but sometime around there, the arm feels pretty good. The surgery itself takes me about an hour and a half, but between getting you back into the OR room, getting you positioned, and then waking you up and getting you to the recovery, the whole round, the whole time from start to finish of when you leave the pre-op area to get into recovery is probably more like 3.5 hours. When you wake up from surgery, you're in a sling, And you stay in that sling for about 6 weeks. And the purpose of the sling is to remind you that you just had a shoulder replacement, to not move your shoulder away from your body or try to do too much with it, because that can cause a problem. We have to let things heal in after surgery. And I'll explain to you the rehab that we do after the reverse shoulder replacement versus the anatomic shoulder replacement, because it's a little bit different. So depending on which one you have to have, the rehab varies a little bit, okay? You have a waterproof bandage that's on place, and that stays in place for about 7 to 14 days, and you can shower with it on. It actually helps prevent infection because it elutes a little bit of silver, which helps keep the incision clean. So we use that bandage, something we started to use over the past few years. And we close the incision with dissolving stitches and skin glue, so you really never have to have any sutures out, which is a nice thing. And so once your pain's controlled, then either you go home if you're in the ambulatory center, or you wind up going up to a room in the hospital for a night, and the therapist sees you and they start to talk to you a little bit, and then you start to progress along over the next few days. Now, from a rehab perspective, these are some of the exercises I have you do basically right away after a shoulder replacement. So as you can see here, these are called pendulums, where you kind of bend over at your side and you start to make these small, gentle circles with your shoulder. If you've ever had a rotator cuff repair, these are some of the exercises that we have patients do as well. I have you come out of the sling multiple times a day to do hand, elbow, and wrist motion, because one of the things you may have noticed if you've ever been put in a sling before is that when you wear the sling constantly, your elbow can actually get stiff. And so we don't want to create a new problem by putting you in the sling. So we have to be very mindful of that. So I always want you to come out of the sling and get that elbow moving very, very quickly after surgery. Now, this is my rehab protocol after an anatomic shoulder replacement or a regular shoulder replacement. Now, you can see here, you're in the sling for 6 weeks. And the reason you're in the sling for 6 weeks and we avoid certain movements after this is because when I do the surgery, I make that incision and I actually just move two muscles apart. I move your deltoid and your pectoralis muscle out of the way. You don't actually have to cut any of that. You actually are staring at that front rotator cuff muscle there, that subscapularis. In an anatomic shoulder replacement, we have to get that subscapularis to heal back down. So in order for me to see the shoulder, I have to release that muscle from where it belongs. We do the replacement, and then I repair it on my way out. That has to heal for the total shoulder to do well. And so basically the rehab you do for the first 6 to 12 weeks is making sure that that subscapularis heals, so we avoid things that really stress that, and that's kind of listed here. And you can see as we progress along, the first thing we do is get your motion back. Once your motion becomes back, then we start strengthening. And once strengthening comes back, then we allow you to do kind of more return to sport type activities. And everybody's a little bit different in how much therapy you need. Some people do really well with a couple of months of therapy. Some people need a little extra. We kind of base how much therapy to do and how much you need on how your recovery is going. So this is on an individual basis, and everybody's a little bit different. So we understand that. This is just my general protocol guidelines. Now, if we do the reverse shoulder replacement, you see that I don't even have you start therapy until 6 weeks after. A lot of the things you can start doing on your own at home, because we don't have to protect the shoulder as much with the reverse shoulder replacement as we do with the anatomic. And again, you have some range of motion limitations there, but it's the same general principles as if you had an anatomic replacement. Now, a lot of the questions I get after surgery are here, and I'll just go over these with you just really quickly. A lot of people ask how long they need to be in a sling. I usually say about 4 to 6 weeks after replacement, you're in a sling. Part of that is to remind you not to do anything silly with the shoulder. The other thing is to remind other people around you not to grab onto you. If you're walking in the city, I mean, not right now, but normally, if you're walking in the city amongst a bunch of people and they see a sling on, they usually tend to avoid you a little bit. So it's almost to remind yourself as well as everybody else around you that, yeah, you just had shoulder surgery, so back off. As far as driving goes, this is usually around 6 weeks. Everybody's a little bit different, so it's a patient-to-patient specific thing, but it's about 6 weeks. A lot of the questions I get from shoulder replacements surround golf. So when can I pick up a golf club? When can I start swinging a golf club? It generally is a progression from chipping and putting to swinging irons to then moving on to a wood and then hitting the driver last. And I usually let you chip and putt around the 4-month mark, depending on how you're doing, and then slowly progress from there, okay? And then there's a question about limitations after surgery. Well, what things can I expect to get back? What things may I not get back? And this actually varies by the type of shoulder replacement that you have. If we do the anatomic replacement because your rotator cuff is functioning well, after surgery, I don't really put much in the way of limitations on you. Do I want you to go back to powerlifting afterwards, or really heavy things that are going to high load the shoulder? Not really, but I really don't put many limitations on you after the type of replacement. With the reverse shoulder replacement, I don't put a lot of limitations on you either, but what you need to understand after a reverse shoulder replacement is because we're changing the mechanics of the shoulder when we do this, you probably won't get as much motion reaching up above your head or reaching behind your back as you would have had we did the shoulder replacement in anatomic way. Now, that's totally based on how your rotator cuff is functioning, so it's not to say that, well, we should have done one or the other. You really only have one option if your rotator cuff isn't functioning. But it's just to understand that sometimes women have a problem snapping their bra with that arm because they can't get their hand behind their back. Sometimes it can get a little difficult to wash your hair if you weren't able to do that before surgery. If you could do it before surgery, we can usually get all of that motion back afterwards. But if you were very stiff beforehand, those may be some things that are a little bit difficult to get back afterwards. So bring it all together. Shoulder arthritis is a different entity than hip and knee arthritis. It's a non-weight-bearing joint, has to position your hand in space, and so it's a very significantly different from hip and knee replacements. The recovery from a shoulder replacement is more akin to that of a hip replacement than it is to a knee replacement. Knee replacements can be hard to recover from. Most people do very well after them, but it takes time. Usually people are doing much better earlier from shoulder and hip replacements just because of the geometry of the joint. Being a ball and socket joint is easier to recover from than a hinge joint like a knee replacement is. Of course, when non-operative treatment fails with shoulder arthritis, then we start talking about a total shoulder and a reverse total shoulder like we talked about. Usually people are going home the same day or the day after surgery with shoulder replacements now because our pain management protocol is pretty good, and we use that medicine I talked to you about to help decrease the amount of blood loss you have. Rehab after really involves getting your range of motion first and then strengthening after. Everybody wants to strengthen as soon as they can. The strength will come. Focus on the range of motion first, and then we'll get the strength back later. And we have a good relationship with a lot of physical therapists around here. And we have a lot of very good physical therapists in and around the New York area. And so we've been very fortunate to be able to work with them. They do a very good job taking care of our patients after surgery. And when I tell patients after a shoulder replacement is usually you feel pretty good by 2 to 3 months, but it takes about 6 to 12 months for you to hit your total end recovery. Now, you should be doing most things well before 6 months, but to see the complete benefit from it, you'll continue to improve for up to a year. So it's always important to keep that in mind when we're talking about shoulder replacements. So I appreciate everybody listening. This was a recent trip my wife and I took before all this started to Japan. I was speaking at a baseball meeting out there, and they were very generous and brought us out there and kind of explored Japan, which is an absolutely fantastic place to visit if you haven't had the chance to visit there. This is my email, and this is my office number. So if you have questions that you don't want to ask today, a couple people on here, of course, I'm happy to answer any of those questions either by email or, we can always set up an appointment and I can see you. So that's pretty much what I have. So Jen, you can open it up to the questions now.
Okay, thank you. If anybody has any questions, again, you can just type them in the chat section, or you can, we'll unmute everybody. You can ask them out loud.
So
I couldn't even figure out how to use the chat, so I'll just ask the question.
Absolutely.
I have pain in the left shoulder, and my left shoulder was crushed in '91, and Jonathan Glashower did surgery. Everything was rosy until I got pulled off a table during breast surgery, and they ruined that surgery, so that was 2012. When I saw the surgeon at Rothman, they said, no, it's got to be a left shoulder replacement. So, and it has to be reversed, okay? My question is, you talked about pain. I have a high tolerance for pain, but the whole arm spasms occasionally. And I think that's due to the problem up here. Can you talk about that a little? Spasming is really a problem for me.
Yeah, so let's talk about that. So the reason that you're feeling that spasm in your shoulder is often because the deltoid, which is the big muscle that runs over the top of your shoulder here, when your rotator cuff is not functioning, because you've seen trauma to your shoulder like you have and things are not in the correct spot, your deltoid has to do a lot more work. And so the more work that does, the more fatigued it gets, and oftentimes it starts to seize up a little bit. You can also get some seizing up of your scapular muscle, so your shoulder blade in your back. So if you think of the shoulder blade as kind of like the foundation for the entire shoulder. So if that's not functioning properly because your shoulder in and of itself is just not in the right spot because of the fractures that you've had, that can also throw off a lot of motion there. It can cause a lot of spasm and pain. So that's not uncommon.
Okay, in '91, the scapula was broken also, as well as the shoulder was crushed.
There you go.
And, it's just been a mess. It was great for almost 20 years. after he did the surgery at Lenox Hill, because that's where Jonathan Glashow was at that time. Thank you for that. The spasming in my left arm is just a mess, and I have no reach up. Like, I can reach up with my right arm, but there's nothing in the left arm.
Yeah, and that's because the rotator cuff's not working. And so that's, like you said, when we talk about the reverse, so we kind of obviate the need for needing a rotator cuff because of how we change the mechanics of the shoulder.
Well, could you be totally honest and tell me what you think is the percentage or of what I'll get back? You know, because I can't even wash my hair with that arm or lift up and put anything in a cabinet.
Yeah. So based on the studies that we've done and some of the literature we've seen, the average motion after a reverse shoulder replacement is about 130 degrees up here. So if you think of being level here is 90, 130 is about up here. So full motion up here is 180. So you're kind of between that. Okay. This getting back here to wash your hair after a reverse, I would say that's probably a 75% chance that you'll get this back because you haven't done it in a really long time. I wouldn't do it for the sole purpose of getting that motion back, but I would do it for, pain and to get you better function. But I would just, make sure you and I have a discussion about if you're going to go back here with it, may not be the best thing.
I was also told that I wouldn't be able to drift the arm backwards. I, thank God, use front hook bras.
Yeah, so the hooking a bra after a reverse shoulder replacement can be difficult because that internal rotation to get your hand back there is a little bit difficult. So I always make sure I talk to my female patients about that because if you don't know it ahead of time and it doesn't, you get annoyed.
But you're sure after 6 weeks I can drive? Because I usually have to time this between my time in New York and my time in Florida, and I have to drive 6 hours to get down to a train.
Yeah, so I would give yourself a buffer of a week or two just to be safe, but it's generally about 6 weeks.
So, and I could probably do the physical therapy anywhere, but I have Spear Physical Therapy that recommended you to begin with the shoulder surgery. Yeah, in Brooklyn.
Yeah, they do a good job.
Okay, thank you very much.
Oh, you're very welcome. Let me see this question here. So, OT therapist based in NYU shoulder patients, worked with some of the reverse patients at NYU, interested in learning about stemless implant design. Yeah, so the stemless implant, Rachel, is available in the United States for anatomic replacements. There are stemless reverse designs, but they're not available in the United States yet, so they're available in Europe only right now.
Okay, great, thank you. Yeah, I thought that was just an interesting design to see, so seeing the x-ray image was great. Yeah,
it's nice because we can take less bone, and so if you ever have to go back and do something later, you have more bone stock. The guys who do hip and knee replacements, they're fortunate in the sense that you got a lot more bone in your hip and your knee than you do in your shoulder. So we have to be very careful about, how much bone we take when we do these things. So we actually take as little bone as possible, getting rid of all the arthritis, of course, but take as little bone as possible so that we have bone stock there in case we ever have to come back. You've probably seen some patients that have had multiple surgeries and it becomes a nightmare after that because it's very hard once you start to lose too much bone. So some of those implant designs have been basically focused on that.
Right. Great. Yeah. Thank you.
No problem.
Does anybody else have any other questions?
Nope, I'm good.
Okay. If anybody has any additional questions afterwards, please feel free to email me, and I will email Dr. Erickson directly, and I'll get the answers for you. I did send our scheduling phone number in the chat, 646-891-5540. That's our direct phone number. If anybody has any questions or needs to schedule an appointment, please feel free to reach out to us, call us directly, or you can just reach out to me directly and I can help coordinate that for you. We are, as I mentioned earlier, Dr. Erickson sees patients in our office in Manhattan at Gramercy and our office in Harrison, New York. We are also doing televisits as well for those that don't feel comfortable yet coming into the offices. But again, I just wanted to thank everybody for joining us tonight. Feel free to email me directly if you have any other questions, and I will be sending the link out probably sometime tomorrow with the recording in case you want to watch it again or pass it along to anybody.
All right.
Thank you.
Thank you.
Thank you. Thanks, Dr. Erickson. Have a good night, everyone.
Thank you.
Good night.
Bye.